Multi-site left ventricular pacing is an advanced evolution of cardiac resynchronization therapy. While standard cardiac resynchronization therapy uses a single lead in a tributary of the coronary sinus to pace the left ventricle, multi-site pacing involves stimulating the left ventricle from two or more distinct locations. The goal is to achieve more near simultaneous depolarization of the left ventricle, especially in patients who have large areas of scar tissue or slowed conduction, that is fragmented QRS. The primary objective is to reduce left ventricular total activation time. By initiating the electrical impulse from multiple points, the wave fronts converge faster than they would from a single point, which reduces intraventricular dysynchrony, increases dp by dt max, the rate of pressure rise in the left ventricle, improving contractility, overcomes dead zones or areas of myocardial scar that might block a single pacing wavefront. There are two primary ways to achieve multi-site left ventricular pacing. One is multipole, that is quadripolar leads. This is the most common clinical method. Using a single lead with 4 electrodes, that is quadripolar, the device is programmed to pace from two different electrodes on that same lead. Example, distal 1 and proximal 4. This has been called multi-point pacing, MPP. Advantage is that it requires only one lead, reduces the risk of phrenic nerve stimulation by allowing multiple vector options. Downside is the pacing sites are limited to the anatomical path of that specific vein. Second option is multiple left ventricular leads. Two separate leads are placed into different branches of the coronary sinus. Example, one in the posterolateral vein and one in the anterolateral vein. Using two leads in separate coronary veins has been called multi-zone pacing. Advantage is that it provides true spatial separation of pacing sites, which can be significantly more effective for widespread dysynchrony. Disadvantage is higher procedural complexity, longer fluoroscopy time, and increased risk of lead dislodgement or venous complications. Multi-site left ventricular pacing is rarely the first line approach. It is typically reserved for CRT non-responders. That is, approximately 30% of patients do not improve with standard CRT. Multi-site pacing is a rescue strategy for these individuals. Significant LV dilatation. In very large hearts, a single pacing site may be insufficient to synchronize the entire chamber. Extensive myocardial scar. If the standard pacing site is near an old infarct, multi-site pacing can help bypass the slow conducting scar tissue. More CRT MPP randomized trial results were published in Europace in June 2025. Aim of the study was to check whether multi-point pacing, that is MPP, was associated with improved clinical outcomes in CRT non-responders. CRT patients were treated with conventional biventricular pacing for 6 months. Non-responders with less than 15% relative reduction in left ventricular and systolic volume were randomized to either conventional biventricular pacing or multi-point pacing and followed up for 6 months. The trial report concluded that multi-point pacing was associated with significant reduction of all-cause mortality or heart failure hospitalization in prior non-responders to conventional biventricular pacing. The devices used in this study allowed sequential pacing pulses to be delivered from two sites on the same LV lead. MSP max from 4 dipoles of 2 LV leads. Acute hemodynamic effect of a novel dual vein multi-site biventricular pacing was reported in JACC Clinical Electrophysiology. left ventricular hemodynamics was evaluated using micromanometer tipped catheter. Configurations tried were single lead conventional biventricular pacing, single lead multi-point pacing, 3-point pacing from distal poles of 2 LV leads, and maximum multi-site pacing MSP max from 4 poles of 2 LV leads. 20 patients with non-ischemic dilated cardiomyopathy and left bundle branch block were investigated during routine CRT implant procedure. Mean LV ejection fraction was 27% and native QRS 171 milliseconds. Significant increase in maximal left ventricular dP by dt compared to conventional biventricular pacing with p-value 0.041 was noted in MSP max, but no other multi-site pacing options.